There is no doubt that all the drugs that we are going to prescribe for patients who fail frontline imatinib can be used in this setting. Ponatinib is one of the choices. I think it's something that we discuss with patients after frontline failure. It's true that ponatinib many times may be indicated as after failure of second generation TKI, as we know that in this setting has the higher effectivity. However, you may consider in certain situations to reuse ponatinib as a second line, because the cardiovascular toxicity associated with this drug, sometimes you have to really wait risk-benefit to really introduce this early on rather to wait until patients fail a second generation TKI. In this case, any of the choices will be nilotinib, bosutinib, or dasatinib. However, it's important to emphasize that in this specific case, all of these three drugs may be associated with side effects that this patient has history of. For example, prolonged QTc. Although prolonged QTc is a class effect, this patient has this problem previously, and for not only for nilotinib, rather for all the TKIs, is something that needs to be taken into consideration and really look after. The second one is the problems with the history of lung cancer and pleural effusion. Although it's not really clear the problems of pulmonary function in this patient, dasatinib may, in patients like that, induce or predispose to really have further pleural effusion. So this is an important factor to be considered. Finally, bosutinib is very well tolerated in this setting. In some cases and in the long follow-ups may be associated with a decrease of renal function, so it's something that also needs to be taken into consideration. Finally, ponatinib after this consideration may be an option, but obviously it's important to produce or to recommend dose modification, because we know that 45 milligrams, that the current dose approved by the label, may be extremely toxic in patients like him. So lower doses of 30 milligrams with even decrease of the dose when the response is achieved may be recommended to substantially decrease the potential toxicities, including the cardiovascular toxicity that have been associated with this drug. In my experience of treatment chronic phase CML with ponatinib, it's important to consider the dosing. Once again, the current approved dose to start therapy is 45 milligrams. However, we know that this dose sometimes exposes to patients to certain toxicities that may ask to reduce the dose immediately. This is the reason that many of my colleagues, including myself, start the doses of 30 milligrams to really see a better tolerance. Having said that, we know that ponatinib today is the more potent tyrosine kinase inhibitor that we have available. We know that it's able to suppress any kinase domain mutation present in the patient and also produce a substantial responses in patients who don't have a kinase domain mutation as responsible for the resistance. This is the reason why ponatinib should be considered for the treatment of patients who resistant CML, who are really failing front or second line generation tyrosine kinase inhibitor, always taking into consideration dose reduction from the very beginning, and as well the patient achieve responses that can be seen very fast with this drug in order to decrease significantly the toxicity in the long run that this drug may be associated with.